So by the end of today, you'll be able to describe and apply basic trauma principles, including LHSC specifics. We're going to describe REBOA, which is recessive endovascular balloon occlusion of the aorta, including the indications, how the procedure is actually performed, evidence for it thus far, and finally, we will have discussed and assessed the future of REBOA here at LHSC. So to help us with this, let's use a case to help frame our learning. So you start taking over the department at 7 in the morning, and you get a patch call from EMS. There's been a 34-year-old female that's been hit just outside of Vic, crossing the street between Vic and Parkwood Hospital. The car was going about 60 kilometers an hour. She was thrown 50 feet, and that's all the information you have right now. So as we do, we're going to turn to our learners, and if I could call on Mark.
So,
what would you have ready in the department when you got that patch?
Okay, so this patient is based on the mechanism alone, is a critically ill patient. So I'm going to want to get my department ready. I'm going to start with getting a trauma team activated. So members of the trauma team, as well as general surgery and ICU at the very least. If I had more specific information about a system that was affected, I would consider getting another service involved. I'm going to want some blood ready. She's female, so O negative blood ready for her. I also want nursing staff ready. I'm going to want point of care ultrasound ready. I'm going to want all my airway equipment ready. That's probably going to be my first priority when she comes in, is IV access and airway equipment. Yeah, and they're going to want all of the drugs ready for that as well.
Awesome. Thanks, Mark. So we've got our people, we've got our equipment, we've got our drugs. So if you move on to Mike BA, is he here? Not here? All right. So in that case, let's go to another PGY2. Are there any other PGY2s that are here? We have Nick and Chantal. Davey's not here. All right. So let's go then to Chantal. I would imagine you'd be able to answer this question for me. What would you say to an examiner? So the patient has now arrived. What would you say? What would you like to have?
Okay, so I want to get the patient into one of the recess rooms. I want all of my monitors on. I want 2 large bore IVs as fast as possible. I want an oxygen mask on. I want to make sure that we have C-spine precautions in place. And then basically just get the patient transferred over. As soon as they get the IVs, they can start getting 2 bags of crystalloid and pumping them in.
Perfect. And so these are your first set of vitals. So heart rate tachy 145, blood pressure hypotensive 78 on 45, SpO2 99% in a non-rebreather, and GCS is 13. So what are your first basic principles, Chantal?
So I think I'm going to just go through my ABCs. As Mark mentioned, airways are first priority. So we know we have C-spine precautions. I'm going to look for trauma around the mouth, see if I need to suction anything out, make sure that the airway's good. She's GCS 13 right now, so unless there's some sort of trauma around the mouth, I don't think I'm going to go for the airway right now. And then breathing, look for signs of attention pneumo. She is hypotensive, so I mean that is obviously a big concern if there's signs of that. Decompress, and then circulation. Not great based on my vitals. I'm assuming we're bleeding somewhere, so Mark's already called for blood. We're already pumping crystalloid, so I'd keep going with that and then move on to the rest of my primary and secondary to find where we're bleeding from.
Awesome. So although today we're talking about the latest and greatest in trauma care, it's always good to stick to our basics. So we heard Chantal just go through basically the primary survey of ATLS. So I was going to call on a PGY1 to ask what those are, but you've already gone through that, so you're a step ahead of me. So this is what you find in your primary survey. So airway, as you said, they have a collar on, and breathing is totally fine. C, pelvis is unstable and your FAST shows fluid in the pelvis. GCS is 13 as we described above, losing 1 for eye opening and for being somewhat confused. And full extremity or exposure, you don't see anything more on log roll. So Nick, what's your first priority of managing this patient? I think we've heard it a couple times, but.
Yeah, so if the pelvis is unstable and you've got a positive FAST, you assume they're bleeding, obviously excessively given her vitals. So you'd want to get the blood going as well. It sounds like we've already started crystalloid initially. So I think getting the blood and calling your general surgery colleagues, if they're not already there, would be appropriate.
Great, so you've heard blood, blood, blood. This time I'm going to call on our expert, Jake, who's all about trauma. What are we going to ask for? Which protocol?
The trauma transfusion pathway.
And why? What's the difference between trauma transfusion and massive transfusion?
So my understanding of the difference is that they're similar in that when you start both pathways, you're going to get 4 units of packed red cells. But thereafter, the massive transfusion protocol, you have to determine what products you want and what ratios. And the trauma pathway is going to come in trauma packs that contain 4 units of packed red cells with 4 units of platelets, and every other one is going to contain a pooled platelets. Everyone's going to come with 4 plasma.
So the super important part to take away from that is that if you go for trauma transfusion, blood keeps coming. Whereas massive transfusion, it can stop, and you can get very busy with trauma protocols. So make sure to, it's often there's confusion, ask for the trauma transfusion. So you move on to your adjuncts. This is the pelvis, so congruent with your physical exam. And this is a chest x-ray, nothing obvious. So the patient next goes to where, Meg? What's the definitive management for this patient?
They need to go to the OR, have surgery.
Okay. This is your next set of vitals. Is that patient ready for the OR?
Not yet.
Okay.
Resuscitated if they're decompensating like that. If their pelvis hasn't been bound, you'd want to bind the pelvis. You're looking after the C in the ATLS protocol there. So you want to make sure you're going with the blood. You have the pelvis bound, but ultimately that's going to be their definitive management.
Perfect. So we wanted to get to that elevator, but we can't leave the room just yet, which is why we're going to be talking about REBOA.
Okay, perfect. Good morning, everybody, and thank you. I just want to take, before I start, the opportunity to say thanks so much for inviting me to come and speak today. It's really cool to actually be in this room talking to a lot of people who have helped train me and will continue to help train me as I transition in my career. So we are going to talk about resuscitative endovascular balloon occlusion of the aorta, and it's fun for me to get to talk about what is arguably the most controversial topic in trauma right now, not only at the major trauma centers, but also here at London Health Sciences Centre. I can't even tell you how many discussions I've had with Dr. Dubois about this since I've been back on staff. So many of you have heard of REBOA, or resuscitative endovascular balloon occlusion of the aorta, but just as a review, REBOA is essentially percutaneous placement of a balloon from the femoral artery up to the aorta with inflation of the balloon in order to effectively cross-clamp the aorta. Though the term is new, the concept is very old, and the picture you see there is actually what is widely credited as the first REBOA, used in the Korean War for exactly this purpose. There were some complications with it, and so it didn't really gain favor again until the 1990s and early 2000s, but it is an old concept that's now being revitalized. And before we get too far into this conversation, I think it's really important that we talk about what REBOA is not. REBOA in its current form may have a very important role in the management of our trauma patients, but that role, at least for right now, is not to replace the concept of resuscitative thoracotomy in the emergency department. For a patient who's arrested, particularly after blunt trauma, we know that part of the resuscitative thoracotomy process is cross-clamping the aorta, which REBOA does. But the other important and potentially more important part of that is opening the pericardium. You can't do that with REBOA, so for now, in blunt traumatic arrest, REBOA is really not indicated. The role of REBOA is for hemorrhage control. It's not a definitive strategy, but it is a very important temporary strategy. So let's talk about what its current role actually is. So REBOA, as it currently stands, is meant for hemorrhagic shock, but really bad hemorrhagic shock. The patient with a gunshot wound to the abdomen who you know needs a definitive operation to deal with that problem, but in your trauma bay has a blood pressure of 50/30, and you don't think you're going to get them there in time to do your operation. It allows a period of temporary aortic occlusion without us having to get in there and get our hands on the aorta, which, as you know, takes time. It can be done in the ER, the OR, and actually in many American centers it's being done in the ICU now for patients who have massive hemorrhage from non-traumatic sources. So back to our case, as you remember, when we left the case with Lauren, we had the patient in the trauma bay with a positive FAST, an extremely unstable and bad-looking pelvic x-ray, which I would argue wouldn't probably respond too well to pelvic binding, who was about to arrest in front of you. There's no question that that patient needs an operation. There's no question about it. But you're really concerned, as am I, that she's not going to make it to the OR before she arrests. And you guys did recognize that. So is this a case for REBOA? And I would argue yes. It's abdominal or pelvic trauma. There's no indication yet for a resuscitative thoracotomy. If you wait a few more minutes, you might have one. But right now, she's not actually dead. So don't go cracking her chest open. And she is very unstable, and as I've mentioned a few times, it's unlikely, particularly in a center like LHSC, where we know that at the best of times, it can take 20 to 30 minutes to have an OR ready. And even if you have an OR ready right now, that's a long hallway and a long elevator ride with somebody whose blood pressure is in the 50s or 60s. So this is exactly the kind of patient where REBOA is probably indicated now. I'm going to take the next few minutes to talk about how the procedure of REBOA is actually done. And this is a listing of the steps for the REBOA procedure, and we're going to go through each one in detail. But before we get to even number one on the list, I pause for a minute to talk about the importance of making sure that you're ready. There's minimal equipment required to perform REBOA. All of it is sitting on that blue towel in this picture, but it's not the kind of equipment that you find, particularly in the LHSC ER, but I would argue in most ERs. You're going to have a hard time finding this equipment. So having it ready, and this is the kit that I used when I was a fellow, in one place is extremely important. It's no different than having a resuscitative thoracotomy or a chest tube tray. You don't need to be searching for things. And what you'll note in the yellow page or in the package, the green page, that's a list of step-by-step instructions on how to perform the procedure, because it isn't performed that often. So how do we perform the procedure? So once you have your equipment ready, the first step is to access the femoral artery. Typically this is done through percutaneous methods using an ultrasound-guided, basically A-line placement. It's an 18-gauge puncture needle that we have in our kit, but any needle will work. And if you happen to have already achieved arterial access to the femoral artery, like for a femoral A-line, totally fine to use that. It's no problem. Once you have arterial access, then the next step is the first wire, and there's a series of wires. You make a small cut right over your 18-gauge needle to facilitate introduction of the first sheath and its dilator. The access needle is then removed, and the first sheath is threaded over the wire using a Seldinger technique. This is typically an 8 French catheter, 10 to 15 centimeters long, and its purpose is to traverse the external iliac artery and end up laying just proximally in the external iliac artery. The reason it's there is to facilitate placement of the stiffer wire, because that soft wire is not sufficient. Once the sheath is in place, you can confirm arterial placement because it has a nice little side port. You pull back on it and see nice red blood, and you'll see that in just a second here. So you confirm your arterial placement. The third step in the procedure, so the initial soft catheter wire is not sufficient caliber to allow for the other sheaths in the balloon to be inserted. So you need to exchange it for a long, stiff wire. That long wire that you see going in is 260 centimeters long, and it's quite stiff, but has a flexible tip at the end to prevent injury to, or hopefully prevent injury to the vasculature. And it gives you, the nice thing about the sheath that's in place is you get a nice straight shot through the external iliac right up into the aorta. Where the balloon is ultimately placed depends a lot on your clinical situation. For patients with pelvic injuries, the goal is to place the balloon or blow it up in what's labeled there as aortic zone 3, right at the bifurcation of the aorta. That's your goal. For patients in whom you're less certain of the bleeding source, then you actually want to place the balloon in zone 1 so that you're getting essentially proximal aortic control. Where you don't want to blow up the balloon is zone 2 because of the vasculature in that area. There's significant risk of injury and also ischemia that you don't want to deal with. So ultimately zone 1 or zone 3 is where you're aiming. And practically, how is that done? Externally, zone 1 corresponds to the midpoint of the sternum between the sternal notch and the xiphoid process. The balloon is measured, as you can see in this, literally by laying it on the patient to the level of the mid-sternum and marking it with a marker. Now, this step differs depending a little bit on where you are. In many institutions that are doing REBOA currently, there is fluoroscopic guided placement. So they have a C-arm or they have availability of fluoro in their emergency department. And if that is happening, then you don't need to do this step of measuring because you're placing the balloon under fluoroscopic guidance. So now you know how long your balloon needs to be. Your stiff wire is in, but the initial sheath, remember 8 French, is no longer sufficient for placement of the balloon itself. Oh. And so we need to take the small sheath out and place the larger, somewhat scary, 18 French sheath that's going to be used to introduce the balloon. And you can see, remember I said 260 centimeters, that wire's really long. That's me as a fellow placing that sheath. So the large sheath is then threaded over the wire. You have to make a bigger cut to facilitate its placement. And as you can see, Dr. Inaba there takes a lot of pressure sometimes to put that in. And that's the scary part for most of us because you're ramming that into the femoral artery. So it is somewhat scary. The term is gentle direct pressure, but I don't know if that's what I would call that. So now you have your appropriate size sheath in place. The balloon can now be inserted itself. Placement is guided by your previously marked spot on the balloon, or again, if you're in a center with fluoroscopic guidance, this is where you use your fluoroscopic guidance. You place the balloon taking into account the length of the sheath. That sheath can be inserted further if it goes easily, but most of the time it doesn't. And then your balloon is in. So now your balloon is in. You know or you hope that it's in zone 1 where you wanted it, and it's time to now blow it up. To facilitate further radiologic identification, we put a mixture of water-soluble contrast and saline in the balloon, 50-50, usually omnipaque, and it can hold 20 to 60 cc's. How much you put in is really a matter of 2 things. First is feel, so you're aiming for apposition of the balloon with the wall of the aorta without rupturing the aorta. So that's a little bit of a feel thing. And more importantly, probably, is making sure it's doing what it's supposed to. So where it's very helpful to have an arterial line in place to see a change or an elevation in your central pressures. That's the most important. So there's a 3-way stopcock on there. You can turn it so that it doesn't deflate. And then finally, you want to confirm if you have time that your balloon is in the correct place. The first picture there is a fluoroscopic view of a balloon dilated. The next picture is in a cadaver, not one we actually did REBOA on. This was for demonstration purposes, I promise. It wasn't our mistakes. But that's what the balloon looks like when it's actually sitting in the aorta. Once you have the balloon up, your next step is to secure it in place and get planning for where you're going next, where you're going to go for your definitive management. Those are really the next strategies that you need to come up with. So that's the procedure. It looks pretty cool. It can be very impressive when you do it. But the next question is, does it work? This article was published in 2013 in the Journal of Trauma, and it's really the first North American series that looks at what happens when we use REBOA in our civilian population. There is lots and lots, prior to this, there was lots and lots of animal data, large animal models that suggested that it does what it's supposed to do. It improves their chances of surviving hemorrhagic shock, and it will work to raise their blood pressure and restore some of their hemodynamics. But like I said, this is the first 6 patients that they published, definitely not the first 6 patients they did, but the first 6 patients that they published who received REBOA, both in Todd Rasmussen's and Megan Brenner's centers. And what the purpose of this paper was to say, yes, it does work. It works to raise the blood pressure, which is basically its goal, with a mean increase of systolic blood pressure on average 55 millimeters of mercury. So very significant if you're remembering that these patients are starting with blood pressures in the 50 to 80 range. And more importantly, it's quick. 5 minutes, mean time to occlusion is about 5.2 minutes. That video I showed you of Dr. Inaba and I doing it, we were 6 minutes. That's how long it took us to get the balloon up. And that's probably reasonable. And one could argue even an ED thoracotomy, depending on the experience of the provider, may not have your aorta cross-clamped any faster than that. And all patients survived their hemorrhagic shock, not to say they all survived in total in this series, and none had complications directly related to the REBOA placement. So there were no vascular injuries or ischemia in this particular series. So this came out and this really sparked most of the interest in the United States. and in Canada about using REBOA in our patients. And a few more studies have come out looking at clinical outcomes. This one's from Japan and represents 24 patients in whom they used REBOA for the purposes of blunt trauma mostly. And again, showed that it works most of the time to improve blood pressure, to get patients to not die in the resuscitation bay of hemorrhagic shock, to get them to the ICU. And what happens after that is generally not talked about as much in these papers, but important. One interesting thing about Japan is that it's actually the ER docs who are placing the REBOA, and they're doing it after they've obtained additional training in IR. There really aren't a lot of trauma surgeons in Japan, so this is not being led by them at all in this group. Like I said, it's ER physicians who've undergone additional training in interventional radiology. And the most recent paper, this was actually published this month, again from Megan Brenner and Holcomb at UT Houston, looking at resuscitative endovascular balloon occlusion of the aorta. And it's a somewhat confusing title because it says comparing it to resuscitative thoracotomy. And that is what they did, but not all the resuscitative thoracotomies were done for necessarily traditional indications. What they tried to tease out was a group of people who had a resuscitative thoracotomy for specifically the purposes of cross-clamping the aorta. So that didn't have tamponade as their reason for having a resuscitative thoracotomy. And again, what they showed was it does work. It reduces death from hemorrhagic shock. Didn't mean everybody survived. There are still lots of patients who go on to die or withdrawn on in the ICU, but they're not dying from hemorrhagic shock in the trauma bay when you use REBOA. The truth is there's no question that it works in some patients. But we recognize that there's a lot that we don't know about REBOA and its role in our trauma patients. And that really prompted Joe Dubose and his group at Shock Trauma to start this national multi-center study, the Aorta study, looking at what happens to patients who, 1, get REBOA, or 2, get resuscitative thoracotomy, or 3, get their aorta cross-clamped from a laparotomy in the operating room. And following these patients prospectively, we're really hoping to get a lot of information on not only the indications, why are people choosing to do one thing over the other, but also the outcomes in the patients who have these various procedures done. And so we're really looking forward to the results of this study. So after that technical discussion, let's go back to our case for a few minutes. So as you saw, that was the video of that actual patient getting a REBOA placed in the ED. We put it in zone 1 and the patient went immediately to the OR. We continued her trauma transfusion, and when we got up to the OR, this is her actual OR video, you can see that we improved her heart rate for sure, so we're working to some degree, at least on her hemodynamics. That's her blood pressure when we had the REBOA balloon down, and I'll just, if I can make it work here, let you watch. So the REBOA balloon's down, and of course we did this only for experimental purposes because we wanted the cool video to show, but we put the REBOA balloon up now, and watch her blood pressure. So it works. There's no question that you can get the blood pressure to go up in most patients by occluding their aorta. So why aren't we doing it in everybody? And the real bane of REBOA, and the question that really needs to be answered is this: what are we doing that's bad for these patients when we use REBOA? So we've talked already about the potential for vascular injury. You're blindly placing wires and catheters in the trauma bay under less than ideal circumstances. And we know that those procedures, even in the vascular or IR suite, can cause injury to the vasculature. The other major one that's reported on is ischemia, lower limb ischemia, because that's, remember, an 18-French sheath in the femoral artery can cause significant downstream complications. And blowing a balloon up in the thorax can definitely cause visceral ischemia. So those have definitely limited things. In that Japanese series that I presented, they had 2 patients with significant lower extremity ischemia, 1 who went on to amputation. Now the question you have to ask yourself, and I don't know the answer, is it better to have an alive patient with complications or a dead patient with none? I'm not sure, depending on the complications, I would say. But I think the most important thing, and I put it under complications, that's not really what it is, but in North America, this is what's limiting us right now. It's nice to watch a video and see how that goes, but technically it's not always that easy to place a REBOA. And right now, that's the type of equipment that's authorized for use in North America. So big sheaths, which means we try to place them percutaneously, but not everybody can. So sometimes you need to do a femoral cut down. And for sure, when you're done, when you're removing it, you have to do a formal repair of the femoral artery. And that definitely means that there needs to be a surgeon involved in this case, because you can't pull an 18-French sheath out, put your finger on it, and hope that things are going to be just fine. It won't, trust me. So that is definitely one of the biggest barriers that we're facing right now. So we think it works, but we think there are problems with it. So if there's a role for REBOA, which again I would argue there definitely is, how are we going to learn it? I'll tell you how I learned. This is a picture of one of my favorite places in Los Angeles. You won't find it on any star map, but it is the old LA County morgue where Marilyn Monroe and Michael Jackson had their autopsies, but now it's not the morgue anymore. It's our fresh tissue dissection lab. It is a very unique experience worked out by some pathologists and people at LA County that all the unclaimed dead in Los Angeles, and there are a lot of them, become the property of our fresh tissue dissection lab. So as fellows, as trauma program members, we have access to this lab basically whenever we want it. And our lab staff have worked very hard to perfect this perfusion model. So we perfuse these cadavers, and essentially it's similar to operating on nearly alive patients. And in LA, this is how we learned. We sent one person to one of the courses, and she came back and taught all of us faculty and fellows in this lab over many days, and then we started doing it on patients. And that was basically our learning process. Now, not everybody has access to that, and I recognize that. So there are courses. These are not by any means the only ones, but they are the two kind of most common ones. The top one is the E-STARS course that was created by Todd Rasmussen and his group. And this is a course that looks at multiple strategies for hemorrhage control, but has a large focus on REBOA. And the bottom course, Megan Brenner, you see her name through all the REBOA stuff, and the group at Shock Trauma have created their own BEST course. And both are largely geared at this time towards surgeons looking for additional training. But that doesn't mean that only surgeons can learn, and not only American surgeons, anybody can really learn. This is from the Air Ambulance Group in the London, UK, and this is a poster that they presented at one of the trauma meetings, looking at the steps towards training people for REBOA. The bottom line is there are lots of people who are interested in this technology, and there are constantly courses, educational opportunities being developed to propagate this technology throughout the world. What is always sort of mentioned, but never, there's no actual answer to, is how should we credential people, centers, to do this procedure? Nobody's currently credentialing anybody short of saying, did you take a course? And that's not necessarily required to perform the procedure. And not only initial credentialing, but how are we going to monitor people moving forward with a procedure that arguably is only going to be performed a few times a year? So there are lots of questions, and we definitely do not have all the answers yet. I put this slide in because I think it's actually a really important thing for us to think about here in London. All the discussion about REBOA is in, at least in North America, large volume, high volume, major trauma centers. There's no question that they have more opportunity to perform the procedure and to obtain expertise in the procedure. But those are the centers where you can have somebody in the operating room in 5 minutes or less. In LA, the trauma bay is around the corner, not a long hallway, around the corner from an elevator that takes you only to the operating room, and the doors open and you walk out of the elevator and you walk into the trauma OR that's ready 24 hours a day, all the time. So the question is, maybe REBOA is better suited for a smaller volume trauma center. Yes, you have the problems of less opportunity and fewer patients that may benefit from it, and by that very nature, less expertise and less experience for the providers. But in a center where the OR and IR are harder to access quickly, 20, 30, however long it takes Dr. Majumdar to come in from home, delay, maybe that's the case where temporary hemorrhage control is actually going to save someone's life. Again, I don't have the answers, but I think it's important to think about as we're moving forward, talking about REBOA in not only our center, but throughout North America. Major trauma leaders are excited about this concept, and of course that means that there will be a current opinion paper in Dr. Moore's journal, the Journal of Trauma. This was published earlier this year, and what did they say? What they said is that for patients who have torso hemorrhage, here's what we think the role of REBOA is. Interestingly, they don't think there's any role currently for thoracic hemorrhage. So in all those ones, it's a little bit hard to read. I apologize for that. There's no role for REBOA in thoracic hemorrhage. What they've really identified is a potential role for REBOA for patients with abdominal or pelvic hemorrhage who have a blood pressure that's less than 80. Similar, or exactly the same as what we've already talked about today, but interesting that it's come out as a formal algorithm in this opinion paper. The other major contribution of this particular opinion paper was the author's conclusion of 7 points for focus of future REBOA research. The focus is largely on the same questions that we're asking. Who should get REBOA? Who are the right patients that would benefit from it? How does REBOA help our patients both in the short term and the long term? And will the availability of smaller, more easily placed catheters make this a more available procedure with a better complication profile? And so this list is basically what's guiding the development of REBOA research moving forward. So using my crystal ball, what's on the horizon for REBOA? This image actually came from the BBC, and I show it to demonstrate for you a very important point. If you look at the bottom, the size of that balloon is much smaller than the one I showed you in the videos. That actually takes a 7 French sheath to place. 7 French. If that is something that's not currently available in North America, not approved by the FDA or Health Canada for use, but if it became available, that takes what is currently attempted to be, but not always, a percutaneous procedure that definitely requires a definitive OR when you're done, and turns it into an arguably completely percutaneous procedure. And that does a few things. Hopefully it decreases the risk profile by not putting that big purple catheter up someone's femoral artery, external iliac artery, and into the aorta, and instead placing a balloon like this. Maybe there's less risk, but also it takes it out of the realm of the surgeon. You don't need a surgeon there if you can place it percutaneously, take it out, and actually use your finger or some vessel seal device to close the hole that you made. So the potential availability of these smaller catheters and with smaller sheaths for introduction may actually make this a much more mainstream procedure, and you won't need a surgeon involved to do it. This is in reference to the London Air Ambulance Group, who you guys know travel with an ER doc, who are starting to perform and have performed REBOA in the field. And what the BBC and this group is actually telling us is that it really works. They've had some really good success with performing it in the field. And again, remember, they can use the smaller sheaths and the smaller catheters, and so some of those complications may be avoided. And it's easier to do because it's hard to imagine how you do a femoral cut down in the field. But if you can do it percutaneously, maybe that's the future. And you can see an obvious benefit for that in patients in our remote locations. And REBOA for traumatic arrest. I think this is on the horizon, if not already being done in many of the trauma centers. And as we continue to improve our ability to rule out conditions that require a resuscitative thoracotomy, pericardial tamponade, massive hemothorax, I think that this is going to become the future, because if all you're trying to do is cross-clamp the aorta, this is an easier, faster way to do that. So I think that there's definitely potential there. So I've just talked for 30 minutes. Now I want to open it up to you guys with the information that you have to get some sense of what you think the role of REBOA could be in London Health Sciences Centre.
Kelly, besides what you already mentioned as far as adverse or complications, are there any other objections that people here, such as Dr. Dubois, have to this procedure?
The vascular group here are at least open to talking to us about it, which is very helpful. Their biggest concern is the potential for injury to the vasculature that they will later have to fix. I didn't put up aortic rupture on that list, but that's also on their list. And the potential, because you're making the decision to place REBOA with about 2% of the information that you actually need to know if it's going to be beneficial, it's possible that there's a major aortic injury that you're going to make worse by placement of this balloon. And I think that leads to the argument as to why this really needs to be done only in patients in true extremis. You need to think, if you're going to do REBOA, that your patient is going to die if you don't. Because doing it, I think, with the current level of evidence, for patients who are marginal, I don't think it's worth the risk. But if you think it's your last option, then I think that's where it's indicated. And I think they're coming around to that concept. You know, the live certainty is better. I don't know, the live uncertainty is better than the dead certainty, but I don't know.
The question is if we are looking at using it here in London, is it solely in the context of this trial, or multi-center trial? Is that it will only be study patients, or no?
I think that's a great question. So currently we are not actually looking to implement it in London today, but I'll tell you in a minute what I think my thoughts are about that. But I would strongly advocate that nobody should have REBOA outside the context of a study protocol at this time. We have, 60, 70 patients in a series, and that's all the evidence we have for the use of REBOA in North America, not even North America. So I think it needs to be done within the confines of a study for sure. Any other thoughts? Can you guys see yourselves doing this after watching those videos? Samir?
In Sydney, they were releasing something very similar to London Hem. So Sydney has a system where they have physicians and paramedics go out, and with the smaller catheters, it is a much easier procedure that can be done. And just for anyone who's sat in the trauma bay watching a bad pelvic trauma patient just hemorrhage out while you're waiting for IR or to get ready, it's frustrating. You can't pour enough blood products into these people. And I've had one of them go south on me, unfortunately die, and I wish there was another option available to me.
Yeah, fair enough. Any other comments from any of the chief residents, the staff? Do you see yourselves doing it? No? Bert's nodding his head. That's not surprising to me at all. Put them on ECMO.
Halfway there.
Just to be clear, it's not the same as ECMO.
Smaller.
Yeah.
Are you able to get the smaller catheter in a trial context to use?
It's currently not. The Americans are much further ahead trying to get it approved through the FDA than we are, but we don't have it right now. And they're struggling with it too. Megan's working hard. Megan Brenner is working really hard to do that. Mason.
Kelly.
Yeah.
So with these severe pelvic injuries, do they ever run into issues where the actual external iliac artery is severed and then you're threading it through nowhere, and how do they go about identifying that before they start dilating in?
That's a great question. So that for anybody who didn't hear the question was, what if the external iliac is already damaged? And you do have to be concerned about that. The problem is there's no way to know it before you start. And it's similar to anything else, right? You wonder if there might be urethral injury, so you're gentle trying to place your Foley and you hope that you don't meet resistance, and if you do, you stop. Nobody's published on those insertion difficulties because of major vascular injuries, but they have to exist. There will be, if we do enough of this, a patient who has a transected or injured external iliac who has an aortic injury that you could potentially make worse. Whether you do or not is a different story, and unfortunately, the urgency of the situation means that you have no way to identify that before you start. There's one more hand up, I think. Yeah, Bill.
Comment that from a procedural perspective, it doesn't look that it's like doing a cell donor technique twice, and with the smaller catheter is probably a bit easier. So from a credentialing perspective, I think that this is really just an evolution of practice. It wouldn't be considered, I don't think, a change in the scope of your practice. It's an evolution, just like any new technology that's brought in and learned. And so it's becomes part of the discipline. So I don't think that's an issue. And Marsha just brought up a great point, which is it looks easier than doing an emergency thoracotomy.
I think that's probably true. If it works, if you can do all the pieces and there's no injuries that make it difficult, the patient doesn't have those super tiny shutdown arteries that many of our 21-year-old abdominal gunshot wounds and skinny young males have. If it works, I think there's no question it's an easier way to cross-clamp the aorta, particularly for people who don't have formal surgical training. There's no question about that. And you guys obviously are the leaders in ultrasound and can be very confident that there's no reason to open up the chest, and I think that that's probably the next step. Drew?
To kind of come back to whether or not could we see ourselves doing this,
Yeah.
I think what I kind of envision just thinking about that is at some point there's got to be that decision point of who should just go to the OR and just get it done. So I think, if you have your extremist, this patient is effectively dead in the next 30 seconds to a minute, then you're going to take your couple of minutes to try and do this. Short of that, you know, we're getting into that gray zone of where do we allow the hypotensive patient that's bleeding to stay hypotensive to get to the OR. I realize you're isolating that circulation that's bleeding now. So I don't know. I mean, I think, you know, where it's going to be in the hands of the emergency physician to make the call to do that is still going to be quite limited, even in a lowish volume trauma center like we are, because it's not that common a position to be in, I don't think.
I agree. I mean, I've been back just over a year now, and I can think of 2 patients, one of which I was involved in, one of which I wasn't involved in, probably your patient, Samir, that you were talking about earlier, who I think would have benefited from REBOA. 2 in over a year, and in the busiest trauma season we've had in 10 years. So, you know, it is worth discussing.
Might see is kind of the middle of the road, which is sick trauma patient, get a femoral artery. You know, and then you're halfway through that that step, that procedure, so that if you need to go to REBOA, you've already accessed the circulation.
Absolutely, and that can't be discounted as important, because when the blood pressure's 40, it's much harder to access the femoral artery, even with ultrasound guidance, than it is when the blood pressure's 70. It really makes a big difference. So.
Obviously outside your trauma, but Adam mentioned an interesting point, which is what about the medical hypotensive patient from AAA? You know,
yeah, absolutely, and there are reports and discussions everywhere about the extended use of REBOA. That's one that's commonly discussed, because when they take the AAA patient to the OR, oftentimes the first step they do is essentially REBOA. They put a balloon up above it and they blow up the balloon so that they don't have to get in and cross-clamp the aorta anymore. So why not extend that to the ER, the ICU? And many of the centers that are routinely practicing REBOA now are actually doing that for medically hypotensive patients, for patients with massive GI bleeds, for patients with AAAs. People where you feel like, okay, if we get temporary control, we can catch up and improve the hemodynamics.
Cord injuries with this?
None that are reported. Just like the risk of ischemia to the viscera, there is risk of ischemia to the spine. I'm sure it's happening, just not being reported. And again, it all becomes difficult to tease out, because remember, if you're placing REBOA in the emergency department, it's probably within 5 to 10 minutes of that patient arriving in your trauma bay. It's unlikely that you're getting a good neurologic exam on them or even a good assessment of all of their injuries. So some of it is we don't know if that injury existed before or if it's a new problem. And that's going to confound this literature moving forward. Yeah?
Kelly, is there any experience at Sunnybrook using this?
They're not using it at Sunnybrook yet.
Not at all?
No. They've talked about it, but to my knowledge, they haven't done it yet. To my knowledge, there's, other than Hamilton, that's the only center that I know of in Canada who's used REBOA so far. I'll tell you my thoughts. I think REBOA is going to come to London eventually. I don't think it's going to come this week or next month, but I think it's going to come here. And I say that because right now with the current technology, you need someone who has surgical training. And as we amass surgically trained trauma surgeons, myself, Dr. Leeper, Dr. Perry, and as we continue to amass them in our trauma program, I think we'll have a critical mass of people that can put this program forward. And as the technology improves, I see it transitioning into the emergency department world in London as well, when you no longer need a surgeon involved, necessarily. You obviously are going to need a surgeon for the definitive management, but not necessarily at the particular moment you put it in. But it's going to take time, and I've alluded to it a few times, but I think the biggest thing we're going to need is buy-in from everybody that's involved. And that's why the discussion and the long process of talking about how we do it, how we monitor our outcomes, how we stay trained to do it, is going to take some time. But I do think it's coming to London.